स्टार्ट करो ठीक है. So hello everyone, welcome to LaparoCareWorld, a premium institute for learning the basics of the surgery. So today I have with me Dr. Sant, he's my RMO, and I have my resident Dr. Bodbole. So today we are going to discuss a small, you can say brief summary of a case of cholecystitis. Actually this is a patient who has presented to us with a symptomatic gallstone disease, but I would like my resident to tell us few important things, the findings that he has seen, the basics that he has seen in this case of acute cholecystitis. So on to you. So give us a small summary of this case. You can come here. You can come on the bed. Give us a small summary of this case.
So good morning, sir. Good morning, everybody. So I'm presenting a case of a 40-year-old male who is a resident of Delhi, who presented to us with pain in abdomen for 1 year. The patient was apparently all right 1 year back, following which he developed pain in the right upper quadrant of the abdomen, which was sudden onset and rapidly progressing. It was associated with nausea and vomiting during that time. He took over-the-counter pills for the analgesics and antibiotics for the same, after which the pain relieved. Since then, he is having intermittent pain in the same region, which aggravates after having heavy meal and which gets relieved on fasting. It is not associated currently with nausea or vomiting, but he complains of mild dyspeptic diseases, dyspeptic symptoms. He has burning in the epigastrium at times. There is no associated bloating or there is no any other associated symptom. He did not have any yellowish discoloration of skin during that time, and even he is not having it right now. It is not associated with hematemesis, just in case to rule out the gastric ulcers or peptic ulcer disease. The patient, he is not having any abdominal distension. He is not having constipation or vomiting, just in case to rule out the obstruction. So in his personal history, the patient is in the past history, it is not significant. He is not a known case of diabetes, hypertension, or any other chronic illnesses. He did not have any past surgical intervention before. In the personal history, the patient is having adequate sleep with normal bowel and bladder habits, and he's having a normal appetite. And the family history is not significant. He also does not have any hemolytic disorders running in the family. So this is a case. I would like to summarize my case, which is a case of abdominal pain, which points down towards the history of gallstone disease, or which might be related to the liver, which we would like to consider further in our examination studies.
So when we talk about the gallstone disease, how do you conclude that this is a gallstone disease, and what findings help you to decide that this is a gallstone disease?
Sir, okay. So firstly, in the gallstone disease, the patient, most of the times the patient is not having any specific symptoms as such. If it is a case of acute cholecystitis, then the patient might have a right hypochondriac pain, which is typically localized with a very severe excruciating type of pain, which is due to parietal peritoneal irritation.
Okay. So I will ask you one very simple thing.
Yes, sir.
Tell me today, how do we, or is there any criteria to make a diagnosis of cholecystitis?
Yes, sir. The Tokyo Consensus Guidelines, which were established in 2019. So these are the latest.
Excellent.
Yes, sir.
The first, let me tell you something about Tokyo. The first
Yes,
meeting that was held in Tokyo was
Yes,
in 2013, and then that was again later on updated in 2018. So 13 and 18 are the two guidelines that have been changed, and these guidelines have been updated for diagnosis of acute cholecystitis.
Yes, sir.
So, do you know that acute cholecystitis is of two types? It can be acute calculus as well as it can be acalculus.
Yes, sir.
So, what do you think this patient is in? Is it patient of acute cholecystitis?
Sir, currently the patient is not having any symptoms, so he is not in acute cholecystitis. So.
Great. So, we have acute cholecystitis due to gallstones, acute cholecystitis due to other conditions.
Yes, sir.
So, can you tell me the other conditions where we can have this?
Yes, sir. So the other part which you asked about, that is the acute calculus cholecystitis. It might be seen currently, which is very common after post-COVID infections. Sir, also if the patient was having prolonged fasting or total parenteral nutrition for a long time, which made stasis of the gallbladder, that might be one of the cause. Sir, if he had any surgery previously by which the surgeon might have cut the vagus accidentally. So, sir, it might be another cause.
Excellent. Yeah, we have infections, we have trauma, we have sepsis. We have a lot of causes associated with acute calculus cholecystitis.
Yes, sir.
So now I want to tell that what are the parameters of Tokyo guidelines. When we talk about the parameters of Tokyo guidelines, the first thing that we have to understand is there are some local signs.
Yes, sir.
Then there are some systemic signs.
Yes,
and then there are radiological signs.
Yes, sir.
So can you tell me what are the local signs that you're going to look for or you are going to ask for in the patient?
Sir, firstly, I would like to look for the Murphy's sign, which is very specific for gallbladder disease.
Excellent. So how do you demonstrate this Murphy's sign? And students, let me tell you what is Murphy's sign. Murphy's sign is defined as a sudden inspiratory jerk, or you can say it's a hiccup like and when you palpate over the right upper quadrant. So can
Yes,
you
sir.
elicit that Murphy sign in
Yes,
the patient?
yes, sir.
You need to take a consent
Yes,
from
sir.
the patient.
या मैं आपको एक बार आपका पेट देखने वाला हूँ, तो आपको कोई दिक्कत नहीं होगी। या तो आप पैर प्लीज मोड़ेंगे आपके घुटने में। या 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 थोड़ा सा नीचे हो जाएंगे तो अच्छा। या थोड़ा नीचे हो जाइए। नहीं नहीं, नीचे नीचे। हाँ, लेटना है आपको।
Yeah.
So, sir, we would like to look for the mid clavicular line in the right upper quadrant, just below the just below the 10th rib. Yeah, right subcostal margin.
Along the mid clavicular line.
उधर देखिए, और जब मैं बोलूंगा तो लंबी सांस लेनी है आपको। लंबी सांस लीजिए। So, sir, as we can see, the patient is not having pain right now. So this is one of the finding which we would like to conclude, that he is currently not in the.
Let me tell you one very. Let me tell you about one very important and interesting thing about the Murphy's is what is the concept of Murphy's? This is the same concept of the McBurney's tendon.
Yes, sir.
So when you have acute cholecystitis, and in that case, the first and the most important thing is that burning gallbladder or burning appendix, when it touches to the peritoneum,
Yes, sir.
actually that is the time that you have the pain.
Pain.
So in case of acute appendicitis, the pain gets referred on to the parietal peritoneum, and that is why it's localized over the right iliac fossa,
Yes.
McBurney's point. And here the pain is actually radiated along that peritoneum, which is supplying the phrenic nerve also, and that is why you have that
Right
shoulder tip pain and an inspiratory jerk.
Yes, sir.
So this is a very common thing. Along with that, suppose if you are not having Murphy's sign, the clinical features or the clinical parameters include one very important thing, the local parameters. Either the patient has right upper quadrant pain.
Yes, sir.
That is also taken as one. So
Yes,
this
sir.
patient is having none of them.
Yes, sir.
Along with this Murphy's sign, can you tell me a place where other than this you have a Murphy's?
Some Murphy's punch, sir. Yes, sir.
Excellent. Where do you see this Murphy's punch?
Sir, we look in the below the angle of the scapula in order to rule out
Can you
renal
show
stone.
me this
Yes, sir.
Murphy's punch
Yes,
in this
sir. Yes.
patient?
आप आगे आप ये बैठ पाएंगे? Thank you. So, sir, we'll palpate the right infrascapular margin, and then we will try to just go laterally and try to punch this region. So, sir, if the patient is having any pelvic perinephric abscess or stones, the patient will wince in pain. So this is the Murphy's punch.
This is Murphy's punch. Murphy's punch doesn't mean that we have to punch
Yes,
the patient with a closed fist. You have to
Yes, sir.
demonstrate. Anyways,
Right.
what is Boas? Can you tell me something about Boas? Have you heard of Boas?
Sir, it is also one of the diagnostic sign of cholecystitis. Sir, just below the infrascapular margin of the right side, there is hyperesthesia of the rib. So even if you touch the patient normally, the patient can wince in pain.
That is what is again the reverse Murphy's. Basically,
Yes, sir.
the Murphy's on the anterior and the posterior subcostal region.
Yes, sir.
Right subcostal, you have the Boas. So let me tell you about the Tokyo guidelines 2013. We have local features, and it includes right upper quadrant pain or a Murphy's sign. Then we have the clinical parameters. In clinical parameters, what are you seeing? Going to see the clinical parameters: presence of, absence of
Yes,
fever, leukocytosis, elevated
Yes,
CRP. These are the classical things. And then the most important is the radiological
Yes, sir.
parameters. So radiologically, if you demonstrate a stone or a biliary sludge
Yes, sir.
or a thickness of gallbladder more than 5 mm or a pericholecystic egoistic shadow, that may be an abscess, that may be a fluid collection, that is also. So what do you think is the, have you seen the USG report of this patient? Show?
Yes, sir. Sir, so firstly, we did a USG after getting this patient, and also we sent his blood for LFTs. So, sir, in the USG, we saw a couple of gallstones in the gallbladder. Sir, there was not, it was currently not associated with any pericystic fluid collection.
Any comment on the CBD?
Sir, CBD looked normal with no dilatation.
However, one thing that you all have to understand, that merely a normal CBD on USG doesn't conclude anything. However, a stone detected on CBD in a USG, this is confirmatory. So it's a high false negative, you can say, value of USG. So if you want to actually see a if you actually want to scan a CBD, the most important thing, the most important investigation is what is
MRCP.
MRCP, excellent. So any comment on the LFT? Is he having any deranged LFT?
Sir, he has mild elevation of alkaline phosphatase. Rest of the parameters like bilirubin and SGOT, SGPT lie within the normal limits.
So since the patient is not having any clinical history of jaundice and the LFT is also normal,
Yes, sir.
basically a borderline elevation of alkaline phosphatase in presence of gallstone may be associated with the adhesions with the
Yes.
nearby structures, or maybe the gallbladder is distended or over distended, and
Yes,
that is
sir.
actually impacting.
Okay, sir.
However, in case of any doubt, we should be going for MRCP in that case.
Yes, sir.
So tell me, what will be your plan for this patient now? And one more thing that I want to ask you: what is the grading of cholecystitis according to this TG13 criteria?
Yeah.
Can you tell us?
Yeah. So, sir, it is categorized into mild, moderate, and severe disease. So the severe disease, sir, while first tell about the moderate criteria, sir, in that the patient is having typical presentation of calculus cholecystitis with fever, leukocytosis count more than 18,000. Sir, I'm not sure about the values.
18,000.
Yeah, then CRP value, raised CRP values with inflammatory parameters. And along with that, if there is any organ dysfunction, then we'll categorize it into severe. And
So
rest,
mild,
yes, sir.
symptomatically, there are apparent no great symptoms. Like if you see this patient, he's having gallstone, he's having a history, but he's not having any comorbidity, any significant parameter which can say that this surgery can be risky. So this is mild. Moderate is somewhere where the pain persists. Generally, students, acute cholecystitis tends to resolve within 24 hours. But if the pain persists beyond 48 hours, 72 hours, basically 72 hours is the cutoff, then you may have a palpable gallbladder. And why this palpable gallbladder? Don't take it as a malignancy. It may be due to mucocele or empyema. So mucocele and empyema, there are exceptions also to the Curvaceous law, which says that palpable gallbladder is seldom
due to stones. Yes,
this is what is very important. And then along with that, if there is any abscess, if there is emphysema, not empyema, if there is emphysematous gallbladder or gangrenous gallbladder, that is also classified as moderate. And severe means any cholecystitis where there is organ failure.
Yes.
It is severe where you don't go for surgery and you go for cholecystostomy.
Yes.
So can you tell me something about cholecystostomy? What is that?
Yeah. So the primary aim of us is to drain the bile which is infected right now. So we'll place a T tube under USG guidance.
Yeah, infected foci has to be taken out. Not a T tube, because T tube is too big to be inserted. At least a pigtail.
Okay.
Pigtail catheter is inserted in the gallbladder, and you take out the bile, you take it for the culture, and you see what it is, and then you will decide. So that was the brief presentation of this case, and now we'll be taking you to the OT, and I'll be showing you the steps of the surgery for you. To keep me followed up on this patient.